Good afternoon, everybody. Thank you for coming. And as you can see, we have assembled quite a big crowd of experts from different areas to debate the method of delivery of cataract surgery called immediately sequential bilateral cataract surgery. So my name is Christopher Liu, and I've been communicating with you. Every person's voice will be heard, but one at a time, as directed by Mr. George Mack. We will have civil behavior, so no fights. We are trying to distill the truth, and hopefully we will be able to. And I assume everybody will be giving their personal view rather than representing a body, apart from perhaps the College of Optometrists representative. Will you be giving your personal view or the college's view? Personal view as well, so everybody personal view. And also I am assuming consent to filming, the purpose of which is for qualitative research and also to get the message out to the open. Please speak freely. If there are any regrets afterwards, then we can edit it out. This is not a college event. It is an event supported by the college, and they've allowed us free use of the facilities. So now we move on to the first item, which will be declaration of interests. Has anybody got any interests they need to declare on this topic? No. And so I'm going to ask you to give a very brief introduction of yourself, basically your name and what you're here for as an ethicist or a religious person or patient. So really just 5 seconds per person. So I'm Christopher Liu, I'm a surgeon.
Bertie Lee, I'm a lawyer. I defend doctors, including ophthalmologists, from time to time.
Juliet Melman-Jones, I'm the Medico-Legal Director of the MPI Group, which is a medical defence organisation, and we support a number of schemes, including one for ophthalmologists.
My name is Daniel Hardiman-McCartney. I'm an optometrist in practice and work with the professional body of optometrists.
I'm Edmund Jessup. I work for NHS England, and we're a funding organisation.
I'm George Mack, and I'm going to be your independent facilitator for the debate. My background is that I've had 11 years of non-executive experience in Sussex in the NHS.
I'm Francisco Pozo Martin. I'm a health economist.
I'm Peter Westoram. I'm a bioethicist and political philosopher.
I'm Chris Leake. I was an optometrist. I'm now an ophthalmic surgeon, and I'm also a ethicist.
Pia Matthews, bioethicist.
Brian Smith, lay trustee at the Royal College of Ophthalmologists and an accountant by training.
Nick Wilson-Holt. I'm actually only here as an observer. I'm standing in for Mike Burden, but I was a member of the NICE Cataracts Committee, and I'm an ophthalmologist.
Stephen Vernon. I'm a consultant ophthalmologist with 32 years experience as a consultant. I also happen to be Vice President of the Royal College of Ophthalmologists at the moment.
John Buchan, I'm a consultant ophthalmologist, 3 days a week and 2 days a week, public health ophthalmologist at the London School of Hygiene and Tropical Medicine.
Andy Pyatt, I'm an ophthalmologist working in Inverness in the Highlands of Scotland. I also provide a visiting service to Orkney, Caithness and the Western Isles, where I perform surgery.
Elizabeth Stratford, I'm a patient.
Matt Broom, CEO of Vision UK and lay member of the Royal College of Ophthalmologists.
I'm Lise Duffy, I'm here as a patient.
Vivian Liu, I'm here to support patients.
I'm Ankam Lee, I'm medical student at Brighton Sussex Medical School.
I'm John Johnson, I'm a nervous patient.
My name is Nyara Zumtengo, I'm a patient plus an ophthalmicness.
Sue Bennett, I'm an ophthalmic nurse and a patient.
Hugh Mackenzie, I'm a Catholic priest representing the Catholic Church, and I've been involved in the Catholic Medical Association on the ethics committee there.
I'm Hosni Hamouda, I'm a Muslim scholar trying to come to have a verdict on the procedure.
Great, so we have two people missing, Ahmed Barden, he'll be coming later, and David Katz, he will be hopefully joining us later, and he will tell us about the Jewish view. So now I'd like to move on to a presentation, and this is the one on 3 pages in different shades of grey. I'd like you to look at the slides whilst I speak. So let me just take you through the rationale of immediately sequential bilateral cataract surgery. So this is a novel, in inverted commas, method of delivery of cataract surgery. So both cataracts in both eyes are dealt with surgically at the same admission. And you can imagine the convenience to patients and their relatives and carers. And on average, because the patient is already on the operating table, only an additional 12 minutes is required to do the second eye. And you can imagine there will be reduced costs to hospital and society. We will be going through its safety and how to take precautions to make it safer, including case selection. And of course, we will be discussing patient choice as well. If we look at the convention of ophthalmic surgery, very often surgery is done in both eyes at the same time. For example, lid surgery, squint surgery, retinal detachment surgery, and refractive surgery. So indeed, why not cataract surgery? Because with the above operations, and including intravitreal injection for wet macular degeneration, they all have risks which can cause blindness. So what is special about cataract surgery that make people fear doing both eyes at the same time? The next slide, the advantages of bilateral surgery. We've gone through some of this already. So 1 pre-assessment, 1 admission, little time added. You learn from the first eye, so when you operate on the second eye, you've already learned how the first eye behaves, and the second eye, being from the same patient, will also behave similarly. If the patient requires a general anesthetic, then it is just 1 general anesthetic rather than coming back the second time and have a second general anesthetic. But in fact, bilateral cataract surgery can be done under subtenons or topical anesthesia. And often the first eye under topical, just with eye drops, and the second eye with subtenons, so they feel a little less when the second eye is operated on. There's only 1 post-op visit. There's 1 lot of waiting for refractive stability, 1 sight test, 1 pair of new glasses, and no period of imbalance between the 2 eyes whilst waiting for the second eye operation. And there's, of course, health economics gain as well. And in fact, it is practiced in a small number of countries outside the UK. So what are the disadvantages? Well, I've always thought that there is just 1 disadvantage, but actually I think there are 2. Well, firstly, you're taking a risk with both eyes at the same sitting, but secondly, the patient will have discomfort in both eyes in the immediate post-operative period. So I don't know how that balances with having 2 periods of discomfort in separate eyes. So in terms of reducing risks, there are 3 things that we do. Firstly, there is the option not to proceed with the second eye if the first eye operation has not gone completely well or has been prolonged. The second thing that we can do is to exclude high-risk eyes, therefore minimizing the risk of something going wrong. And thirdly, there are intricate measures that we do to reduce the risk of bilateral infection or contamination. So let's just turn the page. Let us just expand on the first item of option not to proceed with the second eye. We all know that the risk of endophthalmitis or internal infection, which can take away the sight altogether from the eye, is increased by complications such as vitreous loss, and also by the length of the operation, and also the risk of cystoid macular edema and retinal detachments are also increased by vitreous loss. So if the first eye has not gone well, then there is the option to postpone the second eye to another sitting. And these are the things that could lead us to decide, let's not do the second eye. Therefore, it's not simultaneous. It's actually one after the other, and is not a ballistic decision, because we can actually change our mind after the first operation. The correct term is immediately sequential bilateral cataract surgery, not simultaneous. Excluding high-risk eyes, the next slide. So those eyes at high risk of infection, for example, untreated blepharitis, blocked tear ducts, diabetic patients, those who are immunosuppressed, and those who are allergic to iodine, which is a very effective disinfectant, we may choose to exclude them. If there's a risk of corneal decompensation, say if they have Fuchs's dystrophy, then we won't do both eyes at the same time. There may be lenticular abnormalities, for example, pseudoexfoliation, subluxation, phacodonesis and previous trauma, risk of glaucoma, risk of retinal detachment, risk of biometry error, for example, previous refractive surgery, and risk of intraocular inflammation. So these are high-risk eyes. The next slide, reducing risk of bilateral infection and contamination. So these are intricate measures that we treat the two operations as completely separate operations, changing our gloves, gowns, redraping, making sure the draping technique is perfect, excluding the lashes, and making sure that the operative field is not in communication with the nostrils, a slight face turn to ensure fluid runs down to the ear side rather than pool and cause infection, and surgical team wears full face mask covering both nose and underneath the chin as well. A new trolley of instruments with one Phaco set held back from the previous week. So this particular Phaco set, to be used in one of the two eyes of the same patient, will have proven sterility from a previous cohort of patients. Intraocular lens of different power, and anything entering the eye, for example, balance salt, viscoelastic device, intracameral anesthetic, antibiotic, etc., will have come from different manufacturers or bear different batch numbers. And it is a good principle to reduce the amount of intraocular substances entering the eye, especially when operating on both eyes at the same sitting. Of course, antibiotics is really important to reduce the risk of endophthalmitis. So which eye do we operate on first? And firstly, of course, we must clarify that we're operating on the two eyes when both eyes are visually symptomatic. So the eye we normally operate on first will be the one with more severe cataract. The second point is that if there is a very, very difficult cataract on one side and easier on the other side, then do the easier one first to give a better chance of being able to proceed with second eye surgery. So any form of anesthesia will be fine, GA, topical, subtenons, but in general, avoid sharp needle techniques and avoid intracameral in both eyes. So for example, it could be intracameral under topical for the first eye and subconch under subtenons for the second eye. A scleral tunnel will be safer, but a good long corneal wound is also safe. And if necessary, suture can be placed to increase wound security. So we'll move on to page 3. The prerequisites for offering bilateral surgery, obviously surgeon track record, team track record, hospital track record, and having a hotline so that if there is any problem, then the patient can phone straight away and get seen straight away. And also day one follow-up, either face-to-face or over the telephone. The reality is that phacoemulsification cataract surgery has really become a lot safer compared with previous larger wound surgery. The wounds are now down to under 3 millimeters, and there is really no risk of expulsive hemorrhage. The biggest worry that we have is endophthalmitis or infection of the inside of the eye. The risk of that is roughly 1 in 1,000. The risk of it happening to both eyes, because of the concept of conditional probability, meaning if something were to happen to one eye, then it is also more likely to happen to the other eye. The risk is probably 1 in 250,000 for both eyes becoming infected. Now, it has to be noted that with endophthalmitis, if caught early, then it can be treated successfully. So then we go on to more nebulous things like having good equipment and instruments and that they're serviced and that we have good team spirit and we audit. So are there any questions for this presentation? Anything unclear? If not, then we will move on to the...
Excuse me. Are you asking by that whether we agree with everything you've said, or whether there are any questions concerning what you said?
The latter.
Okay. Not yet. No questions then.
Thank you, Professor.
I had one, Chris, actually, if you don't mind. The question of which eye to operate on first, and I think the suggestion was if one eye was very bad, you do the better eye first. But if one eye was very bad, would you not consider classing that as a high-risk case anyway and just do one eye at once?
Yes, that is a possibility, but you know that it's all grey area. But yes, you have a point there. But on the other hand, it is not impossible to do one good and one bad. However, if they're both bad, then it's a different story.
Presumably the cost of that would be compensated for by the saving in that you mentioned in the bilateral surgery. The question is therefore not so much about the actual definite cost, but how plausible it is that that's going to happen, given that we are in an increasingly resource-constrained situation within the NHS, how stressed people are already.
Peter, thank you. So the reality is that good practice dictates that there should be a hotline in every single hospital offering cataract surgery. So it is just a stronger statement to say that it must be there.
Continuation of existing practice.
Yes. Okay, so we'll move on to the next presentation, the final presentation, with 6 slides. And these are concerns which have been raised by colleagues. So we are looking at money, ethics, training, effect on waiting list, and theatre preparations. All valid, but there could be solutions. So firstly, money. We are paid a certain amount for operating on one eye, but mostly when operating on the second eye together with the first eye, we do not get double tariff either on the NHS or privately. However, we have been able to negotiate 1.95 tariff for bilateral cataract surgery, at least in 2 areas, Brighton and also John Buchan's area. So if you look at the number of operations that can be done per operating list of 4 hours, so we can do potentially 4 patients, 8 eyes, or 5 patients, 10 eyes. There would actually be less strain on the preoperative ward, theatre and post-op teams. I put theatre in brackets because I will explain that at the bottom right slide. Now, why is there less stress? Because we are processing fewer patients. And for our particular hospital, we are putting less strain on a single old lift. The next slide is on ethics, and of course this is what the whole afternoon is about. Let us not dwell on this too much, but it is a matter of, is it acceptable to save money as one day somebody will go blind in both eyes? The counter arguments are, of course, that in America they say that if you separate the 2 eyes, then the risk of dying from a road traffic accident because of your second lot of hospital trips will be higher than both eyes going blind. Now, if you have one eye done and it hasn't gone well, you may actually be put off having the second eye done altogether, which remains, then it becomes a risk of remaining effectively blind for the rest of the person's life. In terms of training, people were worried that if these cases can only be done by a consultant, then trainees will have no work to do. But actually, trainees can do second eyes, and there is no reason why trainees cannot do both eyes under direct supervision. Then people have been worried about the effect on waiting list. We have so much work to do already, so is it ethical to operate on both eyes when there are people waiting for their first eye? Now, 40% of eyes are second eyes, so 40% of patients will return to a cataract assessment clinic and have their operations. What will happen is, if this becomes widespread, then there will be a temporary blip in the waiting list. But then afterwards, because the 40% will not be returning, then it will ease off. So capacity also increases once it becomes running well, so the waiting list will go down. In terms of theatre preparations, the theatre nurses do have difficulties because it takes longer to prepare the instruments and the trolleys, because they all have to be separate. However, I think if this does become widespread, then manufacturers can actually put packs together with left packs and right packs. Then we just pull off the shelf without all these intricate measures. So is everything that I said clear? You don't have to agree with what has been said, but have I made everything clear? Professor
I should like to say at this point that I'm not sure that you've assessed the situation quite correctly, considering your effect on the waiting list. Although you rightly say that 40% are second eyes, what you don't see are the people who don't have their second eyes done, either because they don't need it doing, because they're perfectly happy with the first one, or because they naturally expire before they need their second eye. So I think your effect on the waiting list might be quite considerably more than you think it is from your statement here. Secondly, I know you've negotiated your tariff, but at 1.95, considering what I've just said, then I'm not sure you'll save the country anything, because you will be doing more surgery on one patient than you might have needed to do. And at a saving of only 5% on the second eye, it's actually going to end up by costing the country more. So I'd like the group to consider that.
Thank you. Any other points requiring clarification?
Just to, sorry, that's not, there's be getting into debate, so I'll not say anything.
Thank you. Thank you.
Inappropriate.
So any other points requiring clarification? If not, then I'm going to hand over to Mr. George Mack, who will invite each of you to speak in turn. George, over to you.
Thank you. What I propose to do is to give everyone an opportunity to speak, so I would like people to try and contain what they are contributing to 3 to 4 minutes, so that we can give everybody the same amount of time. I understand some people may need a little bit more time, but overall, on average, that's what I would like. So that will allow us to finish on time at 4 o'clock for a tea break. So what I would like to do to start with is, in order to help us to be as patient-centred as possible, I'd like to begin with a view or two views from the patients amongst us, who I think are at the far end of the table. And so therefore, could I ask, is there anyone there who would like to start the ball rolling?
Yes, I will. I've had a number of bilateral procedures. Last year I had bilateral hernia repair, followed by bilateral cataract surgery, bilateral capsulotomy, and I'm about to embark, heaven help me, on bilateral pars plana vitrectomy for good measure. And I said I was a nervous patient. I'm actually a scared stiff patient, but the medical profession categorises me as nervous. And for a person like myself, I was very appreciative that Professor Liu was able to offer me bilateral cataract surgery rather than one eye at a time. And I think from that I've benefited, and also I was cognizant of the risk of having just one general anaesthesia risk as opposed to two, because I insisted on having general anaesthesia rather than local. And I think that's all I'd like to say at the moment.
Thank you very much, Brian. Is there anyone else that would like to give us an alternative patient view before I open up? Yes.
I was first referred to a consultant in November 2015 and told that I had cataracts. I was 37 at the time. I was told that the right eye was more advanced and would likely require surgery in 5 years' time. Within 2 years, sight had deteriorated, and I went back to the consultant and was told that bilateral cataract surgery would be required at some point, but not simultaneously or sequentially. But the consultant said that he would fit a Technis Symphony toric IOL. I returned home, read about this lens, was very worried about some of the points which came up in some of the reviews. So obviously with 30 years left to go of working, sought a second opinion and was advised completely differently. So I have now had the procedure in the right eye. I can see the filament in street lights, which is a new experience. But I think the primary concern that I had was that the first consultant didn't give me any guidance about what would be best for me in my working life. And I think the point that I'd like to make is that possibility of bias may encroach on decisions for patients depending on a surgeon's particular preference for a lens or procedure.
Thank you.
Just a quick one. I'm not a patient, but I'm here to a certain extent representing patients, and I do think to back that up, I think there's an ethical debate in this more than there is a medical and a money debate about it. It is about consulting your patients and making sure they know what on earth you're talking about, because there's an awful lot of words in here that most patients will never understand. And talking about the lens you spoke about, I don't know what that is. So, I think there's an awful lot of that. I think we certainly need to make sure that the patient is at the centre of this, and this isn't just a debate about whether it's possible to do it or whether it's easier and better for waiting lists, but is it a good thing for the patient?
Thank you very much. Shall I open up? There's another. Sorry, did you want to say something?
I just wondered if it was okay for me to be in the next patient to talk about my experience.
Yes, of course.
Yeah. I'm glad I had one eye first and not the two cataracts done together, because when I first had my right eye done, I distinctly asked the consultant to make me short-sighted, because I've been short-sighted all my life and I wanted to keep reading at night like I do. And then, but I had a surprise, but the outcome of my lens was not what was expected. And so I became very frightened for a few weeks by not being able to see as clearly as I thought I would. And then I was given the option to either have a piggyback lens or to have some correction for the refraction. And I forget what the third option was. But anyway, I decided that with having a family history of glaucoma anyway, if I was going to have a piggyback lens, I was worried that the angle might be shut. So I said, no, I would rather have the lens removed and replaced by another lens. The reason for that was perhaps the consultant explained maybe at the time of surgery, the power of the lens that was supposed to be in the box was different from what was meant to be. Anyway, so at the end of the day, I had the same eye reoperated on, and I'm happier with it now. And then my left eye, which was done later, is perfect. There's no problem with that, but I've ended up one short-sighted, one long-sighted, but I'm happy now.
Thank you.
I'm a patient. But my background is being a patient with bilateral cataracts, and also I do have a clinic which is led by nurses where I look after patients after their cataract operations. So from that experience of nursing patients after their operations, I realized patients get frustrated because their second eyes are not done immediately as they assume when they are spoken to during the process of their pre-assessment and also on the operation day. So they assume that it's going to be immediately. And in fact, when they come for their checkup, they think they're actually coming for their second eyes to be done. And when I explain to say, no, it's going to be at least 2 to 3 months, you can see the frustration, you can see the disappointment, and then having to do things twice, pre-assess, optician twice. So this is where, as an individual with bilateral cataracts, worse in my right eye and a little bit less in my left, I decided to have a bilateral cataract, the immediate, both eyes done at the same sitting, because it meant as a nurse, I would have to have one eye done, go to the optician. My daughter was going to look after me as a student. As a result, she was caring for me. She would have missed the classes twice. So for me, it was convenient. I decided on general anesthetic because some patients have, terrible times in theater. And during the checkup, when I talked to them, they expressed a lot of trauma, nervousness, can't cough, not sure what's going on, and also hearing what is happening when they don't quite understand everything in the process. So this is why I decided general anesthetic, which was okay because I had it once. So I am for the immediate because it benefited me as a nurse. Thank you.
Thank you very much. So shall I ask, is there any other patient who would like to?
Yeah,
you would like to?
I've had bilateral just recently. For me, it was the right choice, definitely. I appreciate, as again, I'm an ophthalmic nurse as well, I appreciate there are lots of people that it wouldn't suit for various different personal reasons. For me, though, the outcome has been brilliant. I was off work for 2 weeks, 3 weeks at the most. I was able to drive, see, I'm virtually glass-free, and I can't have wished for anything better. But I do appreciate, from lots of points of view, that there is discomfort when you have it done. You do perhaps need somebody with you. So people's circumstances are very important, especially in the elderly. Again, I see people that have had one done, the frustration where they haven't had their eye done, they can't get the glasses, they have a lot of imbalance. And of course for me, the imbalance would have been very difficult for me to work. So there are circumstances where it is needed, without a doubt, and I do appreciate the economical advances. I sometimes wonder, because when you start to look at the economic question, are the patients being put first, or people being put first, because I'm a patient as well, and everybody needs to be taken as an individual and assessed as an individual, and on that basis I feel that decisions should be made.
Thank you very much, Sue. Thank you. Right, can I take you first, and then I think you wanted to...
Yeah, sorry. Can I offer another patient perspective? I'm an ophthalmologist in Leeds, but we were, after the NICE guidance came out last year, we were considering whether this is, as it says in the guidance, whether we should consider offering this to low-risk patients. And so I did a focus group. I got 10 patients with some of their relatives in a room, and then I did individual interviews to pilot an information sheet for patients. And I think the key point is one that's coming out here is that we are all individuals, and when in our focus group of 10 patients, it was about half and half. Half said, yeah, probably I would go for bilateral, and half said, probably no, I'd rather see how the first one goes. And The circumstances were as individual as the people, and the reasons and justifications were as individual as the people. And I think this debate, we have to remember, we're not discussing what we're going to do to people. We are going to discuss what people will be offered. And I think it's really it's the ethics of offering the choice. Is it ethical to offer the choice rather than is it ethical to do the thing? And I think that's very important, that we're not doing things to people. It's their eyes.
Thank you very much. Now I promised you next.
From a medico-legal legal viewpoint, the law would very much support that this is a patient-centric decision. Patients need to be told about risks which they consider individually are material, and what one patient might consider to be a material risk, another patient may not consider to be a material risk. So I think I very much echo what my colleague said over there, is that each patient has to be treated as an individual and given a full explanation and understanding so that they can make an informed decision about what is right for them. And I think importantly, the Royal College of Surgeons has issued a really helpful document called Consent Supported Decision Making. And even if surgeons, of course, are individuals too, and each surgeon will have individual preferences as to the type of surgery that they prefer, but the surgeons must not allow their personal views and preferences to have an impact on description or emphasis given for each of the options. I think that's also really important to bear in mind for the surgeons around the table.
Thank you very much, Juliet. Thank you, Ms.
If I could just make some point, again, very much patient-centred. If you have to understand the geography of where I work, and that I have patients on the island of Barra, and they will be seen in a clinic in Benbecula, which is a couple of hours away. Their total journey time when they go to the hospital in Stornoway is 6 hours. So a return journey is 12 hours for them. If I have an old lady in a wheelchair, that journey is going to be very difficult. I might offer her the possibility of same-day cataract surgery. In fact, more often I have patients, before I even raise the subject, they are begging me, please, will you do both on the same day? One said, I can't face the journey. Another said, I've got a patient who, my husband has got dementia, and I've got to arrange care. I'm not going to be able to cope to do it twice. Also, sometimes I will offer patients coming a long distance, we could do one eye on one day in Inverness, and then the next day we'll do the second eye. However, on the islands I do not have that choice, because there is only one surgery per month. When I was in Orkney, I had a patient who was very, very keen for same-day surgery. He also wanted toric lenses. I was the only surgeon prepared to do toric lenses on the island. He'd have to wait 3 months in between subsequent visits. And he was self-employed. He said, I cannot take time off work. And that was his request. So if I've crossed the Rubicon and prepared to offer it for some patients because it's 6 hours, I'd be very grateful. At what stage should I be offering that to patients? At 4 hours? At 3 hours? 2 hours? 1 hour? Half an hour? Or should I be offering it for everybody? I don't know. I'd be very grateful for your advice.
Thank you. Who was next? Would you like to?
My name is David Katz. I'm not. I'm here as it looks, as it seems, in multiple different capacities. So I hope you'll bear with me for a minute or two. I'm Professor of Immunopathology, University College London. So I know a little bit about medical issues. I've also been involved in the regulation of ethical issues at UCL. Both my wife and I are very long-standing patients of Moorfields Eye Hospital. And I think I was asked here through the office of the Chief Rabbi, who A, is a relative, B, is a long-standing patient of Moorfields himself, and very aware of issues relating to bilateral eye procedures, and I represent him on many occasions in relationship to ethical matters. So, against that background, can I start, as people have been starting as a patient, the patient issue that first of all, my wife had lens replacement as a result of a genetic glaucoma condition, and she had them done sequentially. And your experience in relationship to the changes in her vision that occurred as a result of the sequential procedure mean that she, instead of wearing one pair of glasses, she now wears about 3 different pairs of glasses for different kinds of things, because with the best will in the world, one eye is short-sighted, the other eye is hypermetropic, whereas she'd had relatively minor correction beforehand. So I don't know how that would have worked had she been offered bilateral. From my point of view, as a result of medication, I ended up with not only chronic glaucoma in my left eye, but then the exacerbation of that to an acute glaucoma attack with pilocarpine. I'm sorry if the non-medical people don't follow those techniques, but I had an acute glaucoma attack, which I think is an emergency. It's an ophthalmological emergency, and I had, and subsequently I had to have a lens replacement in that eye. And I complicated by having autoimmune uveitis. And again, so I had, for my lens replacement in that eye, I had to have, eventually it was agreed by the immunologists, I suppose they were a little bit scared of me, 120 milligrams orally of steroids in order to cover this eye. I'm now in the situation of awaiting a decision made about my other eye. And given the fact it took me nearly 6 weeks to even begin to get a lens for my left eye, I'm going to be left with my only remaining good eye, having to have, not being able to use my only remaining good eye during the 6-week steroid cover again. So for me, the concept of bilateral surgery would have been effectively, as judged by my past experience, rendered me totally unable to see, and I've only got about 10% vision on the left anyway. So for me, there's a whole issue about the individual patient, and very much an individual patient issue, and which brings me to the reason why, in relationship to the chief rabbi, there are two issues. The one is the question of consent. Sure, this should be on offer, but the question is, how is the consent being obtained? And the Jewish community, unfortunately, has been at the center of the fact of the changes in consent laws that have taken place over the last 70 years. And it's the question of consent, and it's the question of the doctor that is presenting the case to the patient, either for single or for bilateral, has to actually do that absolutely properly and accurately. And consent includes the understanding of risk. And in the Jewish medical ethical world, the concept of risk is a paramount concept. And when you talk about any procedure of any kind, is there risk, and who is the risk to, and how is the risk arranged? And really the issues you raise about accessibility and availability and so on, sure, those would come into play. But the issues about economy, about it being more economical and cheaper to do the bilateral together, would not really be considered to be an important factor. It's rather the risk of what's actually being done, rather than whether you're saving money to NHS or an insurance fund or whatever. So it's those two issues about consent and risk that, if I were to take forgetting about my personal history, if I possibly can, and take it into account, it's those two that reassurances are needed about.
Thank you. I think we should thank you.
There's been a number of very interesting things that stood out in the comments so far. The two main for me is the comment, for me it was the right choice, which is absolutely essential, I think has been said. But the other one thing that I was thinking of in the while I was preparing for the meeting is this distinction. The comment frequently comes up in the literature that there's no additional risk, or the risks are very similar of the two cases, and I think it's important to distinguish between risk and hazard, because I think that that's not as clear in some cases. So the percentage of harm happening is perhaps the same, but the hazard or the severity of what will happen if there is if a risk does occur, if probability goes the wrong way in these things, is very important. So I think this needs to be made very clear and articulated very accurately to patients in a very comprehensive way. Unfortunately, I'm a philosopher, so I'm not sure how you do that, because there is quite a lot of research that shows that it's very difficult to make it clear and for people to understand very complicated things when it's frightening, when people have these other considerations. But I think the quite lengthy process of consent is terribly important, and being aware of the surgeon's responsibility to protect the patient, possibly from themselves as well in certain cases. So I think that has to be at the core of these consent procedures, to make people aware as much as is possible if that's going to be appropriate for that person. But I think these comments on, for me, it was the right thing, and the importance of consent and risk and hazard and severity are vital in these discussions. Thank you.
Thank you. Would you like to?
Thank you. Thanks very much. As I said, I was on the NICE committee with Mike Burden, who was the chairman of the committee, and there was a long deliberation, actually, including quite considerable discussion with our lay members, both of whom have had recent cataract surgery on the committee. And you know, I think it's important to emphasise that consent is absolutely essential, whether it's a single eye or both eyes, and very, very important to have documented evidence that there has been adequate discussion with the patient, and that the patient fully understands the implications. One thing which has not yet been mentioned is the fact that with bilateral simultaneous surgery, one does not have the option of refining the implant to be put in the second eye on the basis of the refractive outcome. That means the lens is needed for the first eye. So obviously that is an important consideration, and therefore that, in a way, helps one decide whether it's appropriate for that particular patient. That obviously will be part of the discussion with the patient and should be clearly documented by the doctor carrying out the consent. That's my main point, actually. The other thing I would just point out, Chris, is I noticed that in your presentation you referred to subconjunctival cefuroxime. I think NICE would recommend the intraocular cefuroxime. That was a recommendation of the NICE guidance. Yeah.
Thank you.
That's just a point.
Thank you very much. I think you were asked to speak next.
If I can pick up on one of the patient perspectives, thank you. One of the patient perspectives that was briefly mentioned, many community optometrists see a roller coaster of expectation with people in the community who experience cataract and they suffer visual impairment, they have their first eye surgery, and they have absolute elation following that first eye surgery, delighted. They go through a period of 6 months or a year waiting for the second eye, constantly worried that they're not seeing as well as they should do, really desperately wanting that second eye surgery with the expectation that they'll have a similar gain as what they had for the first eye operation. And then eventually at some point they have that second eye procedure, and the absolute disappointment they have of that second eye procedure, that it hasn't had the same incremental improvement as the first eye procedure. And one of the things that strikes me about a procedure on the same day is that actually you can have a real improvement in quality of life for quite a long period of time after the procedure, because you don't have that period of hoping things can get better for the second eye and then disappointment. Optometrists will say in the community that for many years after, say, oh, my second eye procedure was never as good as my first, and that can be mitigated through this. Also, a lot of patients do suffer through anisometropia, through difficulty with glasses in that interim period, and I don't think that's probably fully reflected in the literature, and so that may be an area where there may be real gain through doing this. And then picking up on a point you made, I think it would be one of the challenges I'd be interested here today is how you deliver enough information for people to make an informed consent. Because it's a really complicated area for clinicians with lots of different risks and hazards to consider, and I can't picture how you'll communicate that in a very satisfactory way to make a truly informed, objective decision from a patient perspective. So if we can work on that this afternoon, that would be very useful from a community optometrist perspective.
I'm a lawyer. Can I begin by saying that I think that this is a generic problem in medicine. We had exactly the same problems when we started with minimal access surgery, with day of admission surgery, with day case surgery, with interventional radiology, interventional cardiology. All of these things raised exactly the same concerns. On the one hand, it was said to be cheaper, it was less traumatic, it was more convenient for patients, it had more risks, and it was said to be an issue of patient choice. All of these things are generic. The other thing that I want to stress that is generic is the issue of patient choice and consent. We are facing a complete revolution in medical consent to treatment, which the medical profession and the NHS are only beginning to come to terms with. In the first place, we now demand that the doctors counsel patients in terms that they will understand about all of the advantages and disadvantages, not only of the procedure, but all of the alternative procedures. This applies to every medical consultation. If I go and see my GP about a cough and he decides not to refer me, he has to counsel me about all of the obligations. If he's going to be defensible, he has to make a record of that. Then you've got to get on to the Ginger Rogers issues. Ginger Rogers was asked whether or not it wasn't wonderful dancing with Mr. Astaire. And she said, yes, but you've got to realise that everything he does, I have to do backwards wearing high heels. Now, the backwards in this case, I'm working with the obstetricians at St Thomas's Hospital on a project. In the obstetric outpatient clinic at St Thomas's Hospital this afternoon, the average reading age of the patients is 6. Now, don't knock that, because you can read the Sun on a reading age of 6, but 50% of them will be less than average, and they are virtually semi-literate. People alluded to the fact that most of us are in fact medically semi-literate, especially in ophthalmology, which has its own very closed sphere of rhetoric, and we have to master that, and we have to understand the concepts on it. The next thing you've got to understand about that outpatient clinic at St Thomas's is that 25% of the patients share no common language with their doctors, and they speak 75 different languages. So you've got to find a way in which you're going to communicate with people who are semi-literate, who don't share the same language as the doctor, about all of the range of options that you could be offering them, including the ones that you are not offering them. And you've got to do that in a way that records their understanding. My own view is that the consent form is not fit for purpose and should be thrown away. I think that a consent form signed on the day of surgery is prima facie evidence of professional misconduct, because it implies that somebody has counselled a patient and told them about the risks after they have taken the decision, and at a time when we know they are going to be acutely anxious and unable to lay down memory of the risks that are described to them. So what we've got to do, if we're going to get this thing in gear, is to redesign the practice of medicine around the patients. We've got to take the counselling out of the outpatient clinic, because there is no way that any one of you in an outpatient clinic can counsel patients about all of the advantages and disadvantages of all of the different procedures that you are not offering them, and do so creating a record that will stand up to analysis when they sue you many years later. What we've got to do is to recognise that the burden has to be put on the patient,
make the patient do the work. Design an interactive app and a computer program which takes them through a learning process and records their progress on that learning process as part of the clinical record. Take it out of the outpatient clinic. For patients who are IT illiterate, tell them to come to the clinic, and there they will be consulted, not with a consultant who's got better things to do with their time, but with someone of 14 who is highly skilled at helping them through the app. The sort of techies who help me to function with the computer system that my firm has brought in to make my life more or less impossible. So if we design medicine round the patient and work out what the patient's needs are, we will then make the patient do the work of getting themselves fit to take the decisions. And once you do that, then you will find that these problems will fall into place. Yes, it is true that there are obviously very sophisticated arguments to be undertaken between the doctors about the relative ways in which the risks should be balanced and the advantages and disadvantages of these procedures. I was very impressed with the NICE guideline. I thought it was very helpful and very sensible. But I also do understand that individual patients, as we've heard so clearly this afternoon, will have a very different take on this. And rather than formulate advice that you can dish out to the community, make the patients do the work and learn for themselves and recognize that your role in this context is to be a teacher. A doctor means a teacher, and it is your role to help the patients to learn, put them in a position where they will take the decision, and to recognize that sometimes they will take decisions that surprise you. And these are generic problems. They're not specific to this aspect of ophthalmology or to ophthalmology. They are common across the whole of medicine.
Thank you. I'm going to ask Pierre, and then I'll come to Pierre.
Just because we're talking generally about consent here and information, one thing perhaps I noticed here, we've got AMD. There is an issue about some therapies that are being developed that many patients would regard as being unethical. So it's going to be difficult not simply telling people this is what the procedure is. Sometimes we have to let people know that the therapy itself might be problematic for them, particularly from a religious perspective. And we have to remember that as yet another piece of information to give people.
Just to pick up on the legal perspectives, I experienced kind of both ends of the spectrum I feel that you're talking about. So my first referral, I was given no information really about the options. I wasn't really told that there were options. It was like, we need to do this, we need to get you in now. And my second opinion spent considerable time, like a couple of hours, explaining to me why there was a justification for the decision which was made, ultimately by me, what the advice was surrounding that, how we would approach that, what would happen if it didn't quite go to plan, what the sort of backup ideas were. So I think there's this huge scale on which some people are working and some people are not. There are people that are getting no information, and you know, a dual surgery was never on the table for me anyway, for a number of reasons, I believe. But some people get virtually nothing. The consultant says, this is what we will do, and you as the patient, with no medical training, accept that you are with an expert and you therefore sign the forms because that's the advice you've been given. The counter sort of element of that is, I know we can be in a position where we have too much information, but for me, I needed to determine what things would be like post-surgery, and no one could show me a photograph of what I would see on the other side, and really that's what I wanted. I understand why that can't be done, but having the information to process the different options and discussing the different options was absolutely crucial to me actually going into hospital on the day at all. And I had general anaesthetic for surgery. Like my friend here is very, very anxious. But I did feel in possession of the facts. I was aware of what could go wrong and what was likely to go well, and the risks. So I think this sort of scale of understanding is vital as a patient.
Thank you. I've been lenient and given you a second chance, but I think it was very relevant to have that sort of background to the discussion we've been having at this end. Can I move on then to who else would like to speak? Yes.
I think
in this discussion, there's clearly a balance between a lot of the difficult cases that we've heard with things like economics. From the point of view of the Catholic tradition, I think it would support the sort of debate that's going on here. We want to be fair to everybody, for instance. Everybody has a basic value and dignity. And it's important we do that both individually but also as a community. You know, we talk about the common good. So there's going to, you know, we're not going to be able to meet every hard case, and probably someone will go blind, etc. An extra thing I would just throw into these general considerations is what in the Catholic tradition we call the preferential option for the poor. That is to say that those who are the weakest need to have a little bit of bias towards them. When we're arguing about how to distribute the resources and how to be fair, we need to, right at the outset of the discussions, aim at those who have less access to the system, whose lives are more difficult, the poorer people, the weaker people, etc. And that needs to be at the heart of our consideration. So, you know, for instance, in terms of economic resources, I think we believe that there should be more push towards those who are the weaker people in however we define that, both economically and socially.
Thank you for that. Very good point. I look around.
I need to go and give a lecture in about 15 minutes. So I'd just like to challenge some of the disadvantages that Chris has put on his slide, in that I think the list should be perhaps longer than that. And as an ophthalmologist, we all know that a reasonably common complication of routine cataract surgery is a condition called cystoid macular edema. Now, this is a condition where everything seems fine to begin with after your operation, but assuming your operation has gone well, everything is fine, but a few weeks later, your vision drops due to the formation of fluid at the back of your eye in your retina. This occurs clinically between 1% and 2% of cases, and it's a genetic predisposition. We did some research many years ago to show this. So if you get it in one eye, you're very likely to get it in the other eye. If you have your surgery at the same time, you're exactly the same time on the same day, you will probably get it in both eyes on the same day. And even though it usually does resolve, although not always completely, and sometimes it needs quite a lot of aggressive treatment to get it to resolve, you're going to be incapacitated in both eyes for a period of time during which you are recovering, if you do indeed recover. There are some patients who have this condition who end up with worse vision than they would have had if they hadn't had a relatively mild cataract operation performed. So I'd just like to ask Professor Liu whether he considers that is a risk in what he is proposing. That's the first thing. I would like to echo the comments of my colleague on my right, who said about fine-tuning cataract surgery with implant powers in the second eye. I do this all the time. It's called bespoke cataract surgery, where we are interested in the vision that the patient has in both eyes, particularly without spectacles. And the only way of being sure that you're going to get the optimum result for a patient is to know exactly what the result of the first eye is. And quite often you get a surprise in the fact that a patient can actually see quite well in the distance and also close to with one eye, which you'd think is not likely to happen unless you had a multifocal implant. But for some patients this happens either due to a small pupil or due to the particular optical effect of the operation on that particular patient's eye. Now, you won't know that is going to happen if you do both eyes at once. And it often does alter the lens implant and the operation that you do for the second eye. You rule out the possibility of fine-tuning patients and giving a bespoke service if you do both eyes routinely. I'm not saying it's not the right thing to do for some patients, and I have in fact done it for some patients. There are always indications. But I believe quite strongly for most patients, it is the wrong thing to do, as far as my experience as an ophthalmologist is concerned. I could give you many other examples as well, but I realise I don't have the time. So thank you for letting me say that.
Thank you.
Perhaps Christopher could answer my question.
Thank you very much. I think both of you have raised good issues of biometry error and the possibility of cystoid macular edema. So let's just deal with biometry error first. They are nowadays, with improved biometry, not so common. It is actually quite rare to be way out. And if you are, then there are a number of options that can be had. And firstly, patients may not mind so much that they do not require glasses for distance. They may be quite happy to wear glasses. That would be the majority of cases. Otherwise, you can also do refractive surgery on the cornea or have a piggyback implant. And with the specifically designed piggyback implants, they're really quite safe. But in my experience, which is, well, 30 plus years as well, people are not so worried about slight refractive error. So that's the first point.
Can I interact there? I was not talking about significant biometry error. I'm talking about errors which often occur of just half a diopter or 3/4 of a diopter. They are actually quite common, particularly in NHS practice, where you're having your biometry often done after your patient's pupils are dilated. Now, we could talk about that as well. But I'm not talking about the big errors. They're rare, I quite agree. I'm talking about you don't know how an individual operation is going to turn out until you have examined the patient afterwards. And I disagree with you. I think patients are becoming more discerning. Patients are wanting to be able to see after cataract surgery without spectacles. More and more patients that is happening to. And it will increase dramatically over the next few years.
Sorry, Chris, can I just, there was a research study published last year from Northern California looking at 50,000 patients who'd had operations. Just over 10,000 of them were same-day bilateral cataracts. Just under 40,000 of them were on separate days, separated by a few months. And they looked at the refractive outcomes to see whether the ability to choose a second lens did impact the overall refractive error. And they didn't find a difference in their population, of which was a sizable, that's 50,000 patients, that is a good sample size, and they didn't find a refractive error difference between the two eyes. So although intuitively we feel that it ought to make a difference, one would want to have strong evidence that there was a benefit from the ability to choose a second lens. And I totally resonate that I personally spend significant time cogitating about the best lens for my patients in their second eye. However, I'm not personally aware of any research that says that what I'm doing makes any quality of life difference.
Was that a prospective or a retrospective study?
It was a retrospective study.
That answers the question. You need a prospective study to answer that question properly.
I thought the NICE guideline did conclude there was no long-term difference in outcome, didn't it?
It did, yes, it did. One point I'd just like to make as well is that I do some work for the GMC, and there are quite a lot of referrals being made of consultants and ophthalmologists to the GMC with cataract-related issues. I won't say any more than that. But the issue of informed consent is very much on the radar, as one might imagine, and outcomes and the need for subsequent surgery, which has not been adequately discussed at the time of the initial consultation.
That's not really a question for the GMC. That's more an issue of negligence, rather. That's a civil matter, rather than impairment of fitness to practice, which is a whole another level.
So I'll come back to the second issue, which is also valid, that of cystoid macular edema. It is not so common, if there was no complication, to get some prolonged cystoid macular edema which doesn't resolve itself or respond to treatment. And if you separate the two eyes, you are not going to really avoid that cystoid macular edema if it were to happen, if you separate the second eye to be done at a later date. That's all I have to say.
But I may come back, you don't get the visual deficit at the same time. You get it at different times, which means the patient can actually function with their other eye.
Yeah.
So, I mean, I think this is all a matter of balance as to whether you need to take care of this when the majority would sail through.
Thank you. So I think we note this different points of view there. Can I move on? Who else would like to make a point?
When I was first asked to join this meeting, as a non-medical person and not having, fortunately, had any experience with cataracts, I sat down and mulled over it and thought, we need to think about the effect on the different stakeholders involved. So there is the practitioner performing the operation, there is the hospital, the NHS trust, there is the wider public, there's the patient himself or herself, there are other patients on the waiting list who are competing for scarce resources, there are, and one thing that popped out earlier, there are the insurers. Now, in most of those cases, there may be others. In most of those cases, though, to go to the proposed immediately sequential route would be a straightforward win, normally of a financial nature. The cost or the risk is primarily borne by the patient. But if you look at that a little bit more, cost is the wrong word. And as you point out, I thought really well, risk is actually the wrong word, because there's the probability of something arising, but there is also the impact. The probability may be tiny, but the impact is you lose your sight. That's devastating. There is also, as I think you were very helpful in this, there is also, we talk about risk, there is the medical risk of something going wrong on the day, there is then the risk or the inconvenience which follows the process. And that can cut either way. The convenience factor, maybe I'd rather go through one period of inconvenience rather than two, or even benefits. I mean, if you look on the NHS website, you're not supposed to do any housework, I understand, after a cataract operation. Well, no.
That's a benefit.
Oh, well, I would go for two separate periods, quite frankly. I thought it was time for a bit of humour in this discussion. So I thought these were all very good points coming out, and I was very attracted by the points made on consent. The idea of this being a compulsory route I found appalling, but consent, it's very easy to stuff a bit of paper into somebody who's not very well informed in a stress situation, get a signature. I thought, I like your points about the app. One thing I would press for, and we all do it on our house insurance, you have a cooling off period, and maybe that could be factored into it. Consultation, signature, and then people then have a few weeks to walk away, talk to their friends, and say, no, hang on, I've changed my mind. I'd rather do it in two stages than one. So I'll leave that one out there. Thank you.
Thank you. Yes.
So I really enjoyed the discussion, and I just want to introduce myself. My name is Ahmed. I'm an ophthalmologist originally from Egypt and now working in the UK. It's now 2 years in the UK. So my situation, I'm Muslim. I would like to present some views from my point of view as an ophthalmologist who worked in Egypt and here. And the other thing is the Islamic point of view and the ethical point of view behind offering such bilateral procedure. So what I got from the discussion till now can be summarized by a word in ethics, which is autonomy, which is a patient-centered decision. And the consent is not just a consent, it has to be an informed consent. So if we involve the patient in all the scenario of the operation and give them the information enough to make a firm decision, then this, from my point of view, will be enough for the patient to make a decision whether to go ahead or to choose just one eye. I've been involved in so many bilateral cataract surgeries, including our staff nurses. Two of our staff nurses who had cataract surgery in both eyes, they are aware of all the risks that we discussed, bilateral cystoid macular edema that can cause a problem and can affect both eyes at the same time, and they might be crippled by this. They are aware about the possibility of minor refractive errors, and they are staff nurses in ophthalmology, so they can easily make out that this can affect them. But actually, they made the decision to go ahead with bilateral cataract surgery, so this has to be considered. So the informed consent is very important. If we can reach a point that the patient will have all the information and will make his decision, then this would be enough for us to go ahead. About the Islamic point of view, I summarized it in 4 principles from Islam that apply to medical ethics. And those are Islamic legal maxims that we apply to other issues as well. First of all is, in Arabic, is called qasd, which is intention. So what's our intention? This is the first principle. Our intention when we offer bilateral simultaneous cataract surgery is basically to benefit the patient, to relieve the patient's suffering, to try and rehabilitate the patient as soon as possible, try to give the patient a chance to avoid multiple visits to the hospital, multiple visits to the optician to fit glasses. So it's basically to benefit the patient. And also our intention is to benefit the public, and is, of course, not an immoral method to do bilateral cataract. So in Islam, if your intention is to benefit the patient and the public, then you are doing the right thing. There is a sub-principle of this, which is means do not justify the ends. So one is not allowed to use immoral method to achieve a beneficial medical purpose. And in that particular case, if we agree, we are not doing an immoral intervention or something that can be judged as immoral. The second principle is principle of certainty, which is in medicine can be translated as evidence-based medicine. Do we have the strong evidence to do or not to do immediately sequential bilateral cataract surgery? This is a question that we really need to answer. The third principle is injury. Are we harming the patients when we offer immediately sequential bilateral cataract surgery? So of course, harm is not accepted, same as ethics. Do no harm, or primum non nocere. The sub-principle here is that any harm of a therapy should be minimized. And of course, when we do single eye or bilateral cataract extraction, we have side effects and risks that are not avoidable. So what we need to know really is whether the magnitude of risks is high enough to secure the patient's benefit out of immediately sequential bilateral cataract surgery or not. So the risk versus benefit where we are in immediately sequential bilateral cataract surgery. The last one is the principle of necessity. If you are doing something that others believe that it's prohibited, then if there is a necessity, like for example, our colleague mentioned that a patient might not be able to make it for a couple of visits to do both eyes, and in that case, we are allowed to offer something that's not like the routine standard of care, just to help those patients who have a specific problem. And that's all really from the Islamic point of view. Yeah, the last thing I wanted to mention is working in Egypt and working here in the UK, the patient group is completely different. So if I go back to Egypt at some point, I can't really offer immediately sequential bilateral cataract surgery to my patients because of so many variables. First of all, the patient understanding to their health issue and health problem. Even if you give the patient the full information and you try to get out of the patient an informed consent, the patient ends up in, most of the patients in Egypt will say, we'll leave it to the doctor to decide. And in that case, we will be in bias of the surgeon, whether he believes that bilateral cataract surgery is good or bad. So the informed consent will not be like the proper way. So I can't actually offer it to my patients in Egypt, but here, giving the patient leaflets and giving the patients information, sometimes we explain it to them in videos and diagrams. I feel very comfortable giving the patient the information and getting his consent to have bilateral. So the cultural background of the patients and the place we work at is really to be considered. And that's all really.
Thank you. Thank you. I think there are probably cultural factors in the UK as well, in fact, by implication from what you said there. Can I ask Chris? Yes.
I'm very lucky. I'm actually an ophthalmologist surgeon as well. I work out of Moorfields, Mr. Kent, so I don't think I recognise you, so I don't think I operated on your eye. Oh, I hope not. And I'm sat here and I'm hearing all these great ideas and real good insights. And I'm trying to step out of my ophthalmology role and do it from an ethical perspective, trying to think of it from in an ethical context, justice, health justice context. And it's very interesting at the patient's point of view. I really appreciate that, because I mean, ultimately, you know, doctor-patient relationship is a very individual thing. It's a very personal thing. In America, they defend it with the doctor-patient relationship is defended to the hilt from government interference. But we're not in America, we're in the UK. And a cultural way that we distribute our health resources, which I think might not be popular with the present focus on the patient choice, but we do work in a health system with a fixed pot. And when we are spending funds that are unnecessary to spend, or unnecessary spending of funds, we're taking it from somewhere else. Now, I'm an ophthalmologist, so I'm an advocate for people with sight impairment. But I'm sure if there's a chemotherapy, if there's an oncologist here, they'd be arguing for a drug fund for oncology. Geriatrics would also be fighting for their corner for the limited resources. So, as much as it's very important to have informed consent, and it is one of the prime things that defines our relationship now. They no longer trust the doctor to have beneficence for the patient. And I think sometimes we can slightly fetishize. I think O'Neill says it's neither necessary nor sufficient to have consent in healthcare. A lot of our healthcare comes from clean air, or clean water. I don't consent to that. Equally, I can't consent to you killing me, somebody killing me, or someone eating me. But anyway, I think from the ethics I want to bring to this is this higher picture of we are sharing a resource. And I think if bilateral sequential cataract surgery certainly, I feel, will bring a cost saving to the NHS. And I think it's something that should be at least investigated and should not be removed from the table. It shouldn't be the prime motive to force it on everybody, but certainly should be looked at so we can at least start offering it and building it into our practice, because at the minute it's the most performed operation in the UK. It's only going to go up, and at the minute, as going back into my ophthalmologist role now, we don't even consider bilateral sequential cataract surgery unless the patient we feel needs it, so they fall into a specific group. And I think that's something we should change and try and expand it so it's more performed more routinely, or offered more routinely to patients. Because of this reason, we have to realise that we are sharing resources, and I think it's something we should remember.
Can I take up a point he's raised? Chris, you say that we have to have an ethical distribution of resources, and it is true. It's not only in this society, in every Western society, there is a disparity between the resources that society is prepared to expend on healthcare and the quality of the healthcare they demand. And the present crisis in NHS spending is simply a slightly more vivid illustration of something that's a worldwide phenomenon. Now, if you accept that, and you also accept what other people have been pointing about how you've got to have an ethical distribution of resources, not only to the person in the room, but also to other people, other patients of ophthalmology, and indeed other patients who have different disease. You've got to have an ethical distribution of resources. In view of your view, would you be prepared to refuse to offer unilateral surgery to someone with bilateral disease on the basis that they were demanding an unfair distribution of resources?
I don't think I'd bind myself up by it, but I think it's something that I wouldn't remove from the table. I think it's something we have to at least do research. We have to look at what the cost is. I don't think we should force anything on people. I mean, taking a step back, I think a lot of our healthcare, we make that decision a lot. We refuse treatment to people because we don't think it's cost effective. A lot of times, I think that's what NICE, isn't that what NICE do?
Yes, but they're not talking about 5%
of course.
They're talking about £20,000 quality
for quality, exactly.
And all that sort of stuff.
Yeah, I mean, I don't want to get and I think that's the rub, isn't it? That's the rub. It's finding, you know, how much risk would you take for the cost. I think all things, from what I can gather from the evidence, the risk is very small, but it is catastrophic. I'd like to get on a plane that never crashes. no matter how low the risk is.
But you've never been on one that did.
Yeah, exactly. I always remember Burton Russell, when he was in a plane crash, he was in the smoking section, and he said smoking saved his life. And that's a slightly different distraction. Yeah, I agree. I don't think it's something that I would necessarily trap myself in by saying you have to have this because it's for the betterment of the whole of society. But I certainly think it's such a routine operation. It's something we do so often in this country, and it's only going to go up. I think it's a method of delivery which I feel will have cost benefit to the society, to the health pot as a whole. I also think it will bring great benefit to a lot of patients because of the ease of access. You know, we often say, come back next week, come back next week. That's often someone taking time off work. It's a real imposition in someone's life. So I don't think it has to happen, but I think it's certainly something we should be looking at more, and we should not take that off the table. That's what I'm thinking.
Thank you very much. Thank you. So, by allusion from Chris and from a health economics perspective, I would just like to give a snippet of surrounding the cost and cost-effectiveness of immediate sequential bilateral cataract surgery compared with delayed sequential bilateral cataract surgery. So, in a nutshell and very, very briefly, there are very few published studies reporting on the cost and cost-effectiveness of immediate versus delayed sequential bilateral cataract surgery. None of these studies have been done in the UK, and none of these studies have been done in the NHS. And the existing small evidence from these studies is that IS-BCS, so immediate bilateral cataract surgery, may reduce both the average healthcare costs, the average patient costs, and that it may be cost effective. So the little evidence that exists from contexts other than the UK is positive in that direction. I don't know if you want me to go into details of what other studies have found, but basically, do I have 2 minutes? I can report a little bit. Yes. Okay. So, in terms of average cost per patient, so how much does it cost on average to treat a patient? An economic study of a finished clinical trial of IS-BCS versus DES-BCS, so immediate versus delayed. A trial with around 250 patients in each arm, which is a solid number of patients, and published in 2011, found that immediate sequential bilateral cataract surgery saved overall around 450 euros per patient in terms of healthcare costs, which increased to 739 euros when travel and paid home care costs were included for the patient, and which increased to 149 euros per patient when the cost of lost working time was included. Okay, this is in Finland, okay? So I just want to, to highlight that it's not the UK. Okay. A 2010 Canadian economics study of the hospital costs, now we're talking only about hospital costs, of immediate versus bilateral cataract surgery. And this is not a clinical trial, okay? It's just a retrospective review of 66 patient records. Found on average that hospital costs were significantly reduced when performing immediate sequential bilateral cataract surgery to the tune of around 500 Canadian dollars per patient. Again, this is not the UK, it's not the NHS, it's Canada. In terms of cost effectiveness, so now we're moving to incremental costs per quality gained. So basically the criterion that, one of the criteria that NICE establishes as a requirement for adopting a healthcare technology. Basically there's one study only. It's based on a mathematical modeling exercise and a lot of data from the literature and a lot of assumptions as well. But it estimated that immediate sequential bilateral cataract surgery was both cheaper and both more effective in terms of qualities gained. So again, and this is in Canada, this is a study done in Canada. I think to wrap up this sort of snippet of the evidence, I think clearly there's a need to study this, the cost effectiveness of immediate sequential bilateral cataract surgery in the UK. And I know for a fact that there's a colleague of mine, John Buchan here, who is presented a research proposal to do this in the NHS. I know for a fact because I'm also part of the submission. Okay, thank you.
Thank you.
Can I ask for clarification? How much is 500 Canadian dollars in British pounds? Does anyone know how much a Canadian dollar is worth?
300.
It's about £300. So the hospital's saving £300 per patient by doing it same day.
You don't know if they're any better than we are at costing what happens in hospitals.
No.
I think there are still people who haven't spoken.
I think there are indeed. Would you like to? Some of you.
I just want to talk about the Islamic view on the procedure. Of course, Ahmed Bardan, he talked about it, and I think Islam asks you as a professional to know what you're doing. So you have to have the knowledge. So that's from your viewpoint is perfect. From as far as I'm concerned, I look at it from a more general perspective in terms of text and in terms of judging from the procedures and risks, etc. So if you bear with me, I just want to go through it very quickly. I can, Christopher, I can submit this to you if you like by email because it's just systematic, you know, as in the future if someone asks. Again, I represent myself. My exposure again to cataract surgery is via Mr. Hassan Salim, one of the renowned. He's 75 or 76 now, retired a couple of years ago. He was my neighbor and we had very, very close relationship. Otherwise, I'm a telecommunications engineer as well as a scholar. So the default in Islam that matters relating to general needs and well-being of people are allowed unless there is a text specifically forbidding or disallowing such matters. So in Islam, you cannot just say it is not allowed unless and until you have an evidence. To the contrary, worships in Islam are disallowed. You can't just go on worship. You need to have an evidence why you're doing it this way. The text, of course, is relating to the Quran and the prophetic tradition. That the text should be there. There are, of course, no direct text. There are direct texts and indirect texts. In this case, there is no direct text talking about, you know, sequential cataract procedure, etc. But of course, there are the general text that talks about benefits and harm, as of course in the legal profession and in the medical profession as well. So that is consistent with the Islamic view. So you balance both the benefits against the harm. And also the rulings in Islam there are levels of rulings like forbidden, hateful, or abhorred, or allowed, or desired, or encouraged even. So, you know, so that is, there are layers of rulings saying, you know, this is to be encouraged, this is to be forbidden, and so on. As I said, in the absence of direct text, the ruling is based on the generic text, and in this case, it is in Islam. It talks about seek medication, people of God, and also it forbids harm, no self-inflicted harm, nor cause to others. So these are, of course, there are many other textual evidence, but these are the main ones. Being a PhD candidate in the past, I have a PhD, so I'm very much interested in statistics, and also in Islam, it is based on statistics, because you know, any type of medication, even the simplest thing, paracetamol, can kill people or can cause you know, injury beyond repair, you know, kidney failures or something like that. So it is not possible to have medication without any risks. But in this case, we're talking about the double procedure in a sequential and on the same day at the same setting. So, and I have looked at a lot of literature which was sent to me. I'm a very fast reader, and I realized that the increased risk is very small. Now, 1% for me is small, but it's not small enough. But 1 in 10,000 becomes smaller, but 1 in 70,000 is really small. So it is not possible to disallow the procedure based on an increased risk to the patient. So if there is an increased risk to the patient, then it depends on how much that risk is. And I think also I can hear around the table that we may not have as extensive studies on the in the UK as in the United States, for example, this 10,000 case. But nevertheless, it doesn't mean that it should be very different here. So based on what I have said, the ISBCS, and of course, the benefits is not, the patient is in the center of the benefits, is the center of trying to eliminate high risk to the patient. That is for sure. Nevertheless, we need to look at the bigger picture. It is, at the end of the day, and that may sound horrible, but at the end of the day, resources are limited. And for example, Mr. Hassan Salem, he used to travel to poor countries for his vacation, and he does surgeries and come back for free. And in this case, it applies to some of the cases in Scotland, for example, where he's not coming back in a hurry to that place. Maybe next year, when he has the chance, he goes elsewhere. So that actually justifies a double or ISBCS procedure, etc. So the final, in my opinion, the final conclusion, as a generic decision, I think this procedure is allowed, and in some cases it is encouraged. Nevertheless, for individuals who have higher risk, then there is, of course, every patient is consulted, and I can listen to all the consent, and I agree with a lot of that. I think we need more education, but even that, there is a limitation, because at the end of the day, I am very educated, but a lot of these terms, fail me. But I can relate. I know how to relate to what I want and what I need to understand, rather than trying to understand, how you do it, or, for example, the 2 millimeter against 6 millimeters. Mr. Hassan Salim always complained about it, and he said, I've done it all my life, 6 millimeters, and they're giving us hard time to reduce it to 3 millimeters, this key surgery with a folded lens. He always moaned about it. So I understand that, but nevertheless, things move on, and Islam is a modern religion. Islam is forward-looking, and I think in the case of NHS, there is a need to look forward, to try to, to place yourself in the future in terms of benefits, in terms of procedures being, sort of faster than before, minimize the visits, maximize the benefits in terms of economy, etc. So all of that, in my opinion, and that is, again, thank you very much, individual opinion, but if someone asks me as a Muslim, my opinion, I will give them that. So, but of course, if I have more evidence, I will modify it. For the individual patients, they have to be consulted, and those who have higher risks, and I believe that also doctors try to find these with higher risk, diabetics and so on, family history, glaucoma, etc. All of that to say, look, I can do that for you. I cannot, for example, do it for you. But of course, in other cases, I can do it, but you have these risks, and explain to them very, very clearly what are these risks are against the benefits. Once you've done that, then in my opinion, it is ethical. Thank you very much.
Thank you. Yes, I think, Edmund, would you like to say a few words as a commissioner? Please do, yes.
So just, as I said, I work for NHS England, but just to remind, it's personal view, not official. Clearly, if this procedure is cheaper and better, we're going to be in favour of it. I think one of the questions is what happens if this becomes widely adopted as the norm rather than the exception. And I'd just offer 2 or 3 observations on that. Firstly, I don't think we will ever know whether we've made the right decision or not. I don't think our data systems will be up to establishing whether nationwide comprehensive implementation of immediate sequential has the effect that we think it will have. I mean, we do have registers that attempt to track, for example, cardiac surgery or hip replacement, but I actually can't see that happening. I think we have to accept that we will make judgments here in the light of opinion and the information available, but we will actually never know. I think the other issue will be an implementation issue that Christopher's introduction quite rightly put some quite strict caveats on both expertise, technique and indications for immediately sequential, and ensuring that all 3 of those are meticulously observed in a nationwide implementation of this, I think would be extremely difficult. So that would be my contribution to the debate.
Thank you very much, and as you see, you're here in a personal opinion, but it's nice to hear the view of a commissioner as well. So thank you for that insight.
Mr. Burden is here now. He was the chair of the NICE committee.
Yes, it'd be lovely to hear from him too. Yes, please.
Would you like me to give you my opinion on the concept? I can answer the commissioner first of all about his concerns about whether we can answer the question. The answer is we can answer that question. We have a national cataract data set that is actually capable of monitoring 200,000 cataracts a year already, and if we have the right funding we could actually monitor every cataract in perpetuity, so we could answer that question. I can tell you what happened at the NICE Guidelines Committee where this was discussed. Fundamentally, there is a definite marginal benefit to the patient because they get good vision in both eyes immediately rather than 6 to 8 weeks later. There is a probable cost saving to the NHS, and there is a resource reduction. What we didn't do is set against that the what if we blind the patient, because that then seriously puts the health economic costs of managing that individual for the rest of their life up. So we haven't done a full economic analysis. But the fundamental outcome was we asked, slightly jokingly, around the table, hands up, who would have bilateral sequential. And these were people who had spent a long time discussing cataracts, I think, for about 18 months. And I would say about a quarter of the team, including one ophthalmologist and several of the people from NICE, immediately said, I'd have it done. And the rest of us were saying, definitely don't want it done. And this is all about an individual's right to weigh up the risk-benefit analysis as they see it. We all are quite happy and convinced that when we buy our lottery ticket with a 1 in 40 million, that it's going to be us that day. When we talk to individuals on a routine one-eye patient basis, we say roughly there's a 1 in 1,000 chance you will lose a sight. Nobody ever believes that will happen to them. So our ability to really weigh up and fully understand risk is actually very difficult. And it isn't just a question of saying it's 1 in 1,000 times 1 in 1,000. I don't think we really have a full idea of the true risk, because it's not just that in the good surgery practice hands, there have been cases in the past, and it's a long time, but I still remember what happened in Red Hill some years ago, where they did a list of 10 individual cases, somebody got the fluids wrong, and 10 eyes were severely damaged, and had it been, and I think 5 of them ended up being grafted and several lost the sight in that eye because of a technician mistake. And had it been 5 patients, 2 eyes, there would have been 5 patients blinded. So it's actually very difficult to weigh up. And I think whatever we decide today, it is going to be about the appropriate discussion with the patient about the risk-benefit analysis and what they think about it. And I said, you will find some people will say, absolutely for me, and there'll be other people who say, absolutely not for me. And that's on the basis of the patients who have the appropriate, because that's the other thing about the NICE guidelines. If you look at the studies that have been done, the entry criteria to those studies is very strict. There are criteria for refraction and the anisometropia, the other excluding other diseases. There's a lot of caveats that go on to actually even the patients that got into those studies. So NICE concluded that there was no evidence of harm, slight benefit in terms of speed of access of recovery of good vision in both eyes, but we didn't make any recommendations because the strong recommendations because of this. It's down to an individual perception of the risk, and I think that's where it should stand.
Thank you. Did you want to comment on?
I was just support, I suppose, Chris's point. At the end of the day, you are going to restrict the type of consent because you're going to have to offer options based on a cost-benefit analysis. That's going to have to come in, and we already do it. Surely, people are dying because there's not enough chemotherapy, or you have to wait too long for the MRI, or whatever it is. I just throw in my own little point is when you come to do that, we should prioritise the elderly and the disabled, etc. In terms of the economic thing, there should be a greater weight at this high-level decisions about the balance between economic.
Can I address that as well, if you don't mind? I think what we need as a society to recognise that it is absolutely essential that we cost-effectively analyse everything we do in the NHS in total. And the NHS has a mechanism to do that, which is NICE, and it does it best to compare the benefits from a renal transplant to oncology treatments, to cataract surgery, to any other aspect that it's called to do a cost-benefit analysis on. And they do it probably, and I'm slightly biased, I was slightly sceptical when I started as chair, but I think they do it as best as it can be done, and they put a lot of time and thought into it. Cataract surgery is probably the most effective treatment you can have on the NHS in cost benefit. So we are a long way from debating whether one eye or 2 eyes or whether simultaneous versus is the appropriate message. We have, even in ophthalmology, bigger questions of where our money is spent than cataract surgery. It really is that cost effective.
And do you prioritise the disabled then in terms of
how do you mean?
High level, in terms of the high level decisions about how much money you're putting in each place? Is there
I don't take in any consideration disability, other disability. Your sight is so important to you. If you are disabled, that is bad enough. If you can't see, that's worse. If you're fit and well and you can't see, that's bad enough. Both people get the same treatment as far as I can see. There's no prioritisation in that respect at all. This is cataract surgery in your eyesight is so important to your quality of life that if you're fit enough to get to theatre, you should have the operation. And I have done people who've only got weeks to live because it's still a cost-effective way. If you're going to die of your brain tumour in the next 3 months, you want to die seeing.
Yeah. Sometimes the quality of life assessments, using that as a measurement, if you already have a low quality of life, that you can sometimes build in a discrimination against those type of people.
The NICE guideline, it's a very much procedure-based individual quality of life. Now, you as an individual may have to, as a clinician, say, is it appropriate a procedure is done, is it in the best interest of that patient? That is a decision we always have to make as doctors all the time. But the good thing about cataract surgery is it's actually very rare that you have to say you are not suitable for a cataract operation. I can't think the last time, it may be difficult to get it done, and actually in this debate I know full well that we've got a lady who does have major mental and physical disabilities. She's got bilateral dense cataracts. There is a risk for an anaesthetic. She will not be able to tolerate a local anaesthetic, so we are actually contemplating, in her best interest, doing bilateral simultaneous cataract surgery because we don't know which eye, if any, is going to benefit. We know there's an additional significant risk about the anaesthetic that we're going to have to give her. So she is probably going to be the first person I do bilateral sequential cataract surgery on for 15 years because the last time was a similar patient. So I am always weighing up that risk-benefit analysis on the patient.
And that draws on a different thing again, because when we're talking about patients with dementia, which John and I have talked about in the past before, and people with learning disabilities and various other things, there is still that significant increase in, well, actually it's a debate we're having about dementia, isn't it? But there is a theoretical significant increase in ability to deal with life and various other things, even with those other conditions. So I think that's one of the things you have to deal with here is an awful lot of the patients you're talking about are significantly older as well. So actually consent issues often come down not just to the patient, but also their carer or family member or whatever, and you need to be aware of that consent issue as well, because if we're talking about apps and various other things, an awful lot of the patients we're talking about probably wouldn't be able to deal with apps at all, and especially those with dementia or learning disabilities or various other things. So the consent issue isn't quite as clear-cut as you might think, but cataract surgery is such a successful surgery that actually it needs to be done on whoever needs it. It's not actually, it shouldn't be down to, oh, you've got dementia, therefore it's not worth it, because it still is. And it can increase somebody's ability to live their normal life massively. Thank you. Well, I see there's one person who hasn't made a contribution, would like to make one. Let me ask you to.
So I just like to highlight a few points whether this approach, immediately sequential bilateral cataract surgery, is only applicable for bilateral visually significant cataract patients. And secondly, according to our research, although it was a small study, majority of ophthalmologists were not bothered by the fact that there was lack of training or education per se, but it was more of the fact that there was no hospital approval, or they have to face the medical legal penalties that should there be complication occur. And obviously there was a mixture of background of ophthalmologists. There are older and new generations, so newer generations who are more radical in their approach to adopt new approach, ISBCS, compared to the traditional approach, DSBCS. But there was a single most fear factor, which is the risk of endophthalmitis, that is inevitably lead to total blindness. And I feel like we have lack of evidence per se that whether the risk of endophthalmitis would inevitably lead to total blindness, and therefore we are putting the patients at risk. And some of the research that have reported the risk of endophthalmitis related to the ISBCS have not strictly followed the guideline that is set by the ISBCS, the International Committee. And perhaps the newer studies have reported the use of intracameral antibiotics that will perhaps decrease the risk of total blindness linked to the risk of endophthalmitis. And someone mentioned about the fact that we should also kind of bias to people who are poor, and perhaps this use of intracameral antibiotic in poorer countries or countries with low socioeconomic status, whether that use of antibiotic and perhaps that link application to the implementation of this new approach in ISBCS in other countries other than UK is something that we can consider about. Thank you very much.
Thank you. Now we're drawing to the time when I said we would have a break, so what I would like to do is finally ask, has everyone had their say at this stage for the interim before we come to a break? And if so, I'd like just to draw a few threads together. We started with a number of patients talking about their points of view, and I think the clear thing that came across there to me was that the issue of choice and informed consent was going to be a major factor in our debate this afternoon, and so indeed it has proved to be. And I think it's a heavy responsibility. Some feel even heavier than me. I think it may be almost impossible, but I think one has to try to inform the patient as much as one can, and there certainly was agreement to that. There will be issues, and some of them included cultural and also general ability to grasp complex messages, which puts the onus on professionals, and which must make it very important that you have a successful methodology for documenting the informed consent and how that has been arrived at. Ethically, we've had a really good, I think, discussion on the ethics. I think there is, again, I think a clear driver of the benefit for the patient rather than the economic arguments, although the ethics of the economic arguments is there as well. and not to be ignored. And I think I've been slightly surprised to see there's been less enthusiasm, not just around the table, but also alluded to elsewhere, for the individual taking the risk than I guess I had originally thought would be the case, both in the public and here. And I think there are probably very good reasons for that. Having said that, at the moment it is difficult for patients to be given a choice if there are so few practitioners. And one of the things that we perhaps haven't debated enough is when people want this surgery, do we have nationwide universal access to it? And should we decline it if we don't have good access? Is that a problem for us? I think the area of evidence in the UK was probably answered around the table by the fact that I think the other developed countries, if you like, Finland was mentioned, Canada was mentioned, and I think Spain too, have produced some useful studies, but there clearly is a need for further study in the UK on our own experience, and I'm sure that's a research area waiting for attention. On the risk of endophthalmitis, I think that the evidence that's been discussed around the table is that is a much lower risk than is perhaps generally perceived, but it is a catastrophic risk, and so there is a need to make sure that that risk is understood in the decision-making process, but the scale of that risk is clearly articulated. So it's 4 o'clock. What I would like to do now is to pause, give us time to reflect and have a cup of tea, and come back in 15 minutes' time when we can pick up on the issues that people would like to pick up as issues that are still outstanding, and where we can take each of these elements on our list of questions further or reach a consensus. So let's break for tea and come back at 4:15. Thank you.